This video will present the paper "You Cannot Offer Such a Suggestion: Designing for Family Caregiver Input in Home Care System." Let me start this presentation by setting the scope of the study on caregiving during chronic disease. At disease onset, the patient is mainly cared for by healthcare professionals, such as nurses and doctors. As the patient conditions become more stable, patients may manage their own needs better. This is where they experience maximum self-care. However, if the condition deteriorates, the patient may become dependent, and it is likely that the family caregivers will have to assume the responsibility in the provision of care to their loved ones. In this paper, we explore this phase of care. Using remote home safety assessment as a lens, we explore the behavior of family caregiver when acting as a patient proxy during their interaction with healthcare professionals. Previous work on health technology and user experience has largely focused on the interaction between the healthcare professional and the patient, indicated as quadrant A. Where family caregivers are studied, the focus has often been on the family caregiver's own needs, indicated as quadrant B. Missing out an important perspective on family caregivers acting as a patient proxy or advocates to communicate patients' needs on their behalf, indicated as quadrant C. Using this Venn diagram to illustrate, we will be sharing our insights that will contribute to quadrant C and by extension quadrant D. I will now give a brief background about home safety assessment and our implementation tool that will enable tele-remote home safety assessment. Home safety assessment, or in short, I will call it home assessment, is a procedure that identifies hazards and evaluates the suitability of a place for patients with varying degree of physical impairment. This procedure is often performed by a trained occupational therapist prior to patient discharge from hospital. In Singapore, this will typically involve a house visit by an occupational therapist, followed by reviews of the checklist at the therapist's office. Due to the limited availability of trained therapists and increased demand caused by the rapidly aging population, there is a need to upskill the capacity of our limited pool of therapists. Hence, we developed an iPad application that will, using the help from family caregiver, enable therapists to conduct virtual house visits from their own office. In the application, caregivers can see the tasks they need to perform. They will tap onto one of the tasks to start the data collection process. Instruction and guidance will be provided, and caregiver can begin collecting the data as instructed. Once the caregiver is satisfied with the collected data, they can save the data onto the iPad, then transmit this data to the therapist via the internet, and the therapist will be able to start assessing the home environment. Next, I will briefly describe our methodology. We recruited 14 participants who identified themselves as a primary caregiver for the patient who are more than 65 years old, has a history of hospitalization, and has reduced physical mobility. Participants were given a scenario and task to perform a home X application. They were instructed to think aloud when performing the task. During the process, we made observations and recorded notes on user behavior. Next, we chose a mixed method approach, using a combination of quantitative and qualitative tools to help us gain insights. For quantitative, we adopted the system usability scale to determine the usability of our application. We also used a pen and paper home assessment checklist as a parallel comparator to our digital tool. For qualitative, we conducted a semi-structured interview with our participants to understand their relationship with the patient and their caregiving experience. We then coded the transcript on Atlas and performed thematic analysis on these interviews. Through SUS, we found that participants have rated significantly higher for our application over traditional pen and paper checklists. This indicates the strength of our application and value in digitalizing the traditional pen and paper checklist through user-centered design. We also found that majority of the participants preferred home X over traditional pen and paper checklists. Although participants generally found the application to be easy to use, they also feel that the checklists were more comprehensive than the application and suggest that both tools can possibly complement each other. In addition, we also made some interesting observations about user behavior when using our application. Participants seem to ignore the instruction presented on the screen. Through the interviews, we found various motivations that seem to explain such behavior. First, we found that the caregiver exercise judgment based on their understanding about the patient, filter a recommendation that they perceive to be inapplicable. Here we have an example where the therapist recommended a rollator to the patient as mobility aid. When the caregiver attempts to implement the therapist's recommendation, she faced resistance from her mother, the care recipient. And the understanding of the resistance does not arise through formal feedback. Instead, it was through the observation of a mother's behavior by the family caregiver. With this understanding, the family caregiver understood that her mother was not ready for the rollator solution and subsequently ignored the therapist's advice on the rollator. Here, we can see that the user is using their knowledge about the patient and focus the communication to negotiate the needs that is specific to the patient. As a result, they may overlook professional recommendation. This could have a potential negative impact on the patient outcome. Hence, we suggest that the caregiver knowledge and experience should be complemented by input from a trained professional to ensure optimum patient outcome. Second, we found that the caregiver tend to direct the therapist's attention to areas which they think is important instead of what is required by the instruction. And this is manifested through the behavior of ignoring the instructions and instead using the app to capture photos of unrequested area or objects. Here is an excerpt from the Think Aloud session. In this entryway example, we found that instead of following the instruction given, the family caregivers will make their own interpretation of the instruction. We found this interpretation tend to be based on the family caregiver's understanding and assumption of what is important and needed. Third, we also found that the experienced caregiver can contribute their expertise to healthcare professionals to improve patient outcome. Here, we have P13, who has been a caregiver for her mother for 7 years. She found that there is a potential fall risk due to wet floor caused by her mother's urine incontinence. As this is a change of home environment that is unique to her mother's physical condition and her interaction with the environment, the nurses and therapists had missed the identification of this hazard. The caregiver can potentially be better advised if the therapist has made known about this environmental dynamic. Lastly, the caregivers also desire to communicate their own needs. Long-term caregivers has to make adjustments and develop new habits to their routines in order to provide care to the patient. Here, we have P4, who has been caring for his bedridden wife. Through the interview, we learned that the caregiver may experience fatigue and burnout due to change in lifestyle routine and increased care burden. From these findings, I would like to conclude by sharing 2 design implications for home care system. First, home care systems should recognize the home expert. We found that home care system is an area where medical expertise meets home expertise. Although there has been call for more collaborative partnership between family caregivers and medical experts, we continue to find disjunct between what the healthcare professional wants to know and what the caregiver wants to communicate. Alignment of the communication goals between these 2 types of stakeholders is critical in creating a sustainable care practice that will benefit the patient. In our work, using our findings, we reorganize the order of the tasks based on the home tour that are led by the family caregivers. When we presented this design flow to the therapists, they indicated that this new approach supported their understanding of the home context better than a series of logically ordered but not necessarily meaningful locations. Second, we found that home care system offers an opportunity to also provide care for the caregivers. While incorporating care for family caregivers in patient care can seem to be an unnecessary dilution, we argue that it is important to recognize the tremendous care burden on family caregivers, especially when they are given more care tasks. We think that the Caring for Caregiver initiative can begin from the healthcare organization itself. Although this may seem to be outside the scope of the system development, there is a possibility that certain implementation of Caring for Caregiver features may increase the burden on healthcare professionals who operate on these systems. Yet, it is important to disentangle this tension to improve support to care delivery by the family caregivers. One way to address this tension is that there can be an intermediary role, such as the telecare nurse, that fills in the needs of maintaining an open channel of communication for the caregivers and the patient. That is all for the presentation of our paper. Thank you for watching our presentation. Details of the design of Home X can be found at tinyurl.com/FamilySIGCHI 2020.